Good evening, everyone. So, welcome to our webinar on evaluating and managing galactorrhea by ma'am.
Hello.
So, ma'am, welcome, ma'am.
Thank
So,
you.
we're going to begin with questions first, right?
Yes.
Yes, ma'am. So, we can start.
Okay. Good evening, everybody. And today we have taken a topic of galactorrhea. But before galactorrhea, let me answer your questions. I'll read out the question and give you the answer. The first question is subclinical thyroid treatment. Subclinical thyroid treatment is indicated unless the patient is not indicated unless the patient is pregnant. If the patient is pregnant, we have to give it and maintain the TSH as per the pregnancy trimester level. If it is subclinical hypothyroidism, just follow up the patient with serum TSH every 6 months. When the serum TSH goes more than 10, then you may start with a small dose of thyroxine. Then there was a second question, any formula for dose versus treatment? There is no formula like this because thyroxine requirement depends on multiple factors. Therefore, we have to go by trial and error method. What we can do is regular monitoring. So every 3 months, you can monitor the serum TSH level. If it is high, increase the dose slightly or go on increasing the dose till you reach a normal level. Okay. So there is no fixed formula. It is not an antibiotic. It is a biological hormone. So depending on the biological factors, the dose will vary. Then the third question was, if a patient is having menstrual disturbances and is diagnosed with hypothyroidism, started on therapy, how long does it take for the menstruation disturbances to get rectified? Now, let me tell you, the classical menstrual disturbance of hypothyroidism is menorrhagia. And menorrhagia will be controlled the moment you control the hypothyroidism. But you have said menstrual disturbances. And I also have told you that when there are, nowadays the clinical picture is changing because the serum TSH levels are available to us. Therefore, you can subject a patient of infertility, scanty menses, irregular menses. So all types of menstrual disturbances, you can do their thyroid functions. If they're normal, well and good. But if there is some abnormality, then you may treat it. Okay. But menstrual disturbances are multifactorial. There are many hormones which are involved, and therefore only by treatment of hypothyroidism or correcting hypothyroidism, the menstrual disturbances will not be rectified. The next question was, on the day of blood examination, should the patient take Thyronorm? Yes. Because when we are doing it, we want to see whether the TSH levels are controlled with whatever dose that we are giving. And therefore, we should give. On empty stomach, the patient has to take and go and give the blood. Empty stomach, the patient has to take the tablet. So let the patient take. There is no harm. Like diabetes, we want to see whether the blood sugar is controlled or not. He has to take anti-diabetic drug and then test the blood. Then there was the next question, autoimmune thyroid treatment. Probably the doctor has misunderstood that because there is an autoimmune thyroid problem, therefore we have to treat the autoimmune problem like we treat other autoimmune disorders with prednisolone or something like that. But here, autoimmune thyroid treatment is not different because autoimmunity, the autoantibodies against the thyroid, they slowly destroy the thyroid, resulting into hypothyroidism. Okay, so they are slowly destroying the thyroid and causing a hypothyroidism. So the treatment is replacement therapy. There is nothing else. Then there is another question. Usually the test is done on empty stomach. It is not necessary. It is the laboratory for their convenience tells you to do it on empty stomach. It is not necessary. You can do it You know, most of the hormones, their peak levels, I mean, the pituitary hormones or hypothalamic hormones, their peak is at 3 a.m. And then they start stimulating the other endocrine gland. Therefore, in the morning, the levels will be high, but that does not mean it has to be on empty stomach. Okay. So you can do the thyroid hormone levels at any time, preferably in the morning. Now, when I tell my patient, I'm just giving you an analogy. The diabetic patients, I ask for post-lunch blood sugar. So the patient should take his breakfast, take his tablet, take his mid-morning snacks, lunch, and 2 hours after the lunch, I ask. The moment he goes to the laboratory, the technician there, who is not even qualified, will advise him, nahi, nahi, kuch khali pet ana. And then he will do khali pet. Then he will ask him, go to the hotel outside, eat something and come back. This is absolutely wrong. Therefore, there is no need to test the thyroid functions on empty stomach. He can have a breakfast and get it tested. Is the life expectancy different in the hypothyroidism? No. If you have controlled it, it is the same, like a normal higher life expectancy. Next question was, what is the difference between total T4, total T3 and FT3 and FT4? When these hormones are secreted by the thyroid and they are released in the blood they get bound to the plasma proteins. Thyroid binding globulin, TBG, thyroxine binding globulin, thyroxine binding prealbumin. Okay, and a small portion of that is free and it is circulating in the blood as free T3, free T4, and this free T3 and free T4 are the active fractions. I'll just give you an example. During pregnancy, the thyroxine binding globulin levels increase. Have you followed me? So during pregnancy, so many changes, physiological changes take place. So these TBG levels are high, and therefore when we measure total T4, the total T4 also will be high. And we will make a mistake if we say that this total T4 is high, so the patient is hyperthyroid. It is wrong. The total T4 levels are high because the TBG is high. Okay. Previously, when this free T3, free T4 were not available, we used to do total T4 and T3 resin uptake and take a ratio and find out how much is the free fraction. Today, since free T3 and free T4 are available and they are active fractions, and therefore we should measure them. So we are not misguided by the TBG or TBPA levels. So therefore we do free T3 and free T4. The next question was, a euthyroid patient. 1 minute. For goiter, which is euthyroid, if patient goes for surgery, is there a risk of developing hypothyroidism? I did not fully understand this question. The patient has goiter, the patient is euthyroid. So it is a euthyroid patient going for thyroid surgery. If the patient is going for thyroid surgery, or if the patient is going for another surgery, there are two different types. Now, if the patient is going for some another surgery and his thyroid functions are normal, nothing to worry, he can undergo that surgery, whether it is appendicectomy, cholecystectomy, or anything. All right. Now, we come back to the euthyroid goiter. And that goiter, the patient for some reason wants to get operated. Will he develop hypothyroidism? It all depends on the surgeon. When we were students, the surgeons used to remove 7/8 of the thyroid and used to leave behind 1/8 of the thyroid. And this 1/8 of the thyroid will regenerate and used to secrete the T3 and T4 in a normal range. Nowadays, most of the surgeons, they remove total thyroid, because what happens, whatever small portion of the thyroid that you have left behind, this portion will again grow, because we don't know what is the stimulus for a goiter. So this portion will again grow and the patient will again come back with goiter. And then the patient will say, what the surgeon has done, my surgery has failed, I have again developed the goiter. So nowadays, surgeons remove the whole thyroid. And if they have removed or if they have done a total thyroidectomy, then naturally the patient will require a replacement surgery with because he is now hypothyroid. Okay. Then there was a question how to start cabergoline, that I'll be doing when I do the galactorrhea. When a hyperthyroidism can be said to have progressed into thyrotoxicosis. I think I have gone back. Okay. Okay. This is another question. When the hypothyroid, when a hyperthyroidism can be said to have progressed into thyrotoxicosis, let me take it little later. Now there is another question. If we have treated hypothyroidism and the patient's TSH is 0, can we say it is well compensated hypothyroidism? See, we can't say compensated, we can say controlled. But when the level is 0, then we cannot say, because my answer is no. Why no? Because serum TSH levels normally are 0.4 to 4.5 micro international units per ml. So they are never 0. Today, our radioimmunoassays are so sensitive that we can go to low levels of 0.005 or even lower than that. Okay, so the TSH can never be 0. The normal TSH is 0.4 to 4.5 micro international units per ml. So if you are treating a patient with atroxin or thyronorm, then your level should come down to the normal range. We say up to 10 micro unit, we will say, okay, hypothyroidism is well controlled. Or you can be little aggressive and bring the TSH levels to 4.5 to 5. Now, when you are treating the patient and monitoring with this serum TSH level, if the TSH level falls to less than 0.02, see, you asked me a question whether TSH is 0. We can measure less than 0.02. So if this is less than 0.02, probably your atroxin dose is high and the patient is going to develop, because of your dose, hyperthyroidism. So if with atroxin therapy, if your TSH level is so low, then might as well reduce the dose of atroxin so he does not go into a hyperthyroidism, which is iatrogenic. Then there was another question about malignancy. Okay. And when it was about the malignancy, all the goiters, the question was all the goiters should be subjected to FNAC. See, if it is a multinodular goiter, clinically you see it is a multinodular goiter, might as well do a sonography. If the sonography is showing some cyst, then you can do FNAC, because 20% of the cystic lesion can have malignancy. So do USG, it shows a cystic lesion, you can do FNAC. At the same time, when you put in a needle, you can also aspirate the cyst. So without surgery, his swelling disappears. I used to aspirate this cold or cystic lesion, and from one patient, I had aspirated 67 ml of fluid. The swelling disappeared. Okay. Very, very rarely, there can be a reactionary hemorrhage into that cystic space. So, your surgeon should be on call, or if an ultrasonologist is doing under the ultrasonic guidance, it is very good. So if it is a cystic nodule, do FNAC. Then if you are doing a thyroid scan, on thyroid scan, you find a cold nodule. This cold nodule should be assessed by sonography. And if it is a cold nodule, cystic nodule, do FNAC. And lastly, non-functioning adenoma, also FNAC should be done. I'll just give you this example. treatment of subclinical hyperthyroidism. There is no treatment for subclinical hyperthyroidism. If the patient has little symptoms, you can give beta blockers, particularly propranolol, and keep the patient on follow-up. On follow-up, you can do every 3 months free T3 and free T4. If they're rising, then you can treat the treatment. I mean, you can start the treatment of hyperthyroidism. Then there was a question, is there any specific diet for thyroid problems? You know, on the Google, they have given lot of diets and other things, but I don't believe so. They have said the cabbage contains thiocyanates and therefore can block the iodine uptake and develop goiter. But for that, you have to eat tons and tons of cabbage, which we don't. And therefore, I don't think there is any specific diet. About iodine deficiency, our government has already fortified our salt and other food products with iodine, so we don't have iodine deficiency. Okay, and therefore there is no specific diet for hyper or hypothyroidism. Now, this was a nodular goiter. When I did a radionuclide scan, this area is cold. Now, this could be a non-functioning nodule or it could be a cyst. And when I did the sonography, this was a cyst. So cyst can be aspirated, it will disappear completely. And you can do the cytology in this patient. As I told you, 20% of the cold lesions could develop malignancy. Now this is, I had shown you this slide last time. This is only left side which is taking up radioactive. I mean, this is a thallium scan. The right side, there is no uptake at all. And I had told you, either there is the lobe has not developed and therefore compensatory hyperplasia of that node. The left lobe. Okay. How do I say it is compensatory? That T3, T4 will be normal. But suppose if this is the enlarged lobe and the T3 and T4 is high, then this could be a toxic adenoma. So this is an adenomatous change in the thyroid. This is an adenoma which is secreting more T3 and T4. And because it is secreting more T3 and T4, patient is toxic, but at the same time, that T3 and T4 has suppressed the right side of the lobe, which is dependent on TSH. Okay. So this is a toxic adenoma. Let me see what is the next one. Okay. Now, sometimes it happens that you have a big lobe like this, okay, but it is not picking up any thallium or radioactive iodine. So we call it as non-functioning adenoma. If it is non-functioning adenoma, we should do an FNAC. Because in FNAC, if you get a follicular adenoma, it is not functioning. It is not secreting T3, T4. But if it is a follicular adenoma, it's a little tricky situation. And this follicular adenoma, we should subject for surgery. Because in follicular adenoma, when we do FNAC, we are not seeing the capsule. So there could be a capsular invasion. If there is a capsular invasion, it could be malignancy. Therefore, we have to take out the whole of that follicular adenoma. In follicular adenoma, surprisingly, it has also happened that the patient remains silent, the whole lesion, I mean, you have taken out the follicular adenoma, patient is absolutely okay, and maybe after 10-15 years, the patient develops metastatic deposits in the lymph nodes. So that is a very tricky situation of follicular adenoma. So non-functioning adenoma, you will do FNAC. Cold nodule, you will do sonography and then do FNAC if it is a cystic lesion. And then coming to the surgery. There was a question. So when the surgery is advocated, the indications for surgery is, now see this lady, such big 2 lobes. She had come down from Gorakhpur. Okay, that is the sub-Himalayan region, which is supposed to be iodine deficient. Such huge thyroid gland. With this, she was living for last 20 years. When we suggested her surgery also, she said, for what? I'm not suffering from anything. I don't have any problem. Why surgery? Now, in such cases, when there is a goiter which is huge, but the function is normal, we have to look for signs of compression. So we will take the X-ray of the neck for thyroid. We will take AP and lateral view. And what you will see, when there is a huge thyroid enlargement, the trachea will be deviated on one side, or we can see tracheal compression. And we should not wait till the patient develops tracheomalacia. That means those cartilages become so weak that it becomes difficult for us to do endotracheal intubation during anesthesia. And therefore, if you are seeing that there is any weakening of the trachea, deviation of the trachea, or compression of the trachea, that is an indication to subject a multinodular euthyroid goiter for surgery. If there is malignancy, of course, surgery. And then there are some very fussy ladies, they do thyroid surgery for cosmetic reasons. Or some surgeons also put it in their mind, or they create a fear psychosis, that this may turn malignant, so it is better that you remove it. Okay, nobody can predict malignancy. So it is mostly done for cosmetic reasons. And I tell them, even if you remove it, the remaining part will grow, or you will see a nice necklace around your neck because the scar is going to remain, all sorts of things. And therefore, it is an indication is cosmetic surgery. All right. Otherwise, multinodular non-toxic goiter or any goiter which is functioning normally and not giving any compression can remain like this, and patient can live happily. So these were your questions which I have tried to answer. Okay. Now there was a question, what is the difference between hyperthyroidism and what is thyrotoxicosis? Very intelligent question. Hyperthyroidism means thyroid is secreting high levels of T3 and T4, which has suppressed the TSH. So high T3, high T4, low TSH. Hyperthyroidism. Hyperthyroidism will have its own clinical manifestations like palpitations, sweating, increased appetite, loss of weight, tremulousness, increased frequency of bowels, and scanty menses or amenorrhea. Remember, when there is a hyperthyroidism, there has to be a goiter in the neck, because the thyroid has to enlarge if the thyroid has secrete more and more T3 and T4. Okay. And therefore, that is a hyperthyroidism. Now you will ask me, what is thyrotoxicosis? Now this high T3, high T4, it is producing systemic symptoms and signs. When is it called as toxicosis? The Grave, yesterday only, 25th May, they were celebrating Grave's discovery of this. So Grave had described his first case of thyrotoxicosis as a triad of goiter with hyperthyroidism. I told you, hyperthyroidism, a pakka hyperthyroidism has to have a goiter there. Okay. So goiter with hyperthyroidism. Second, he said triad. The second is Graves' ophthalmopathy. So exophthalmos, proptosis of the eye, lead lag, chemosis, all those, thyroid eye signs, thyrotoxicosis eye signs. So that is ophthalmopathy. So patient has hyperthyroidism with a goiter, of course, Graves' ophthalmopathy, and pretibial myxedema. On the sheen of the tibia, you will get myxedema, non-pitting edema. Now, for some reason in India, this pretibial myxedema is not commonly seen. And therefore, if you see goiter with hyperthyroidism and ophthalmopathy, we call it as thyrotoxicosis. Okay. So that is a little difference between the hyperthyroidism and thyrotoxicosis. I said when there is a hyperthyroidism, there has to be a goiter, and goiter, naturally the normal place of thyroid is in the root of the neck, at the base of the neck. If you don't find a goiter there, then you should search for a goiter. It may be retrosternal. Okay, but there has to be an enlargement of the thyroid if it is a true hyperthyroidism or toxicosis. There is another, now I'm just deviating you for a minute. There is another terminology which is called as thyrotoxicosis fictitia. Fictitia, fiction, fiction, which is not a real story. So thyrotoxicosis fictitia, what is false thyrotoxicosis? Here the patient comes with symptoms and signs of thyrotoxicosis, hyperthyroidism, tremulousness, breathlessness, loss of weight, palpitations. So you do thyroid level. There is a high T3, high T4, but there is a low TSH. So fits in very well with hyperthyroidism. But there is no thyromegaly. And that differentiates. So much hormones are coming out, and where is the thyroid? If I do a thyroid scan in this patient, scan will not show any thyroid tissue, because this patient on a slide, maybe for obesity or some other reason, is taking thyroxine. So inadvertently, if the patient is taking thyroxine and if the dose is more, this patient will have thyrotoxicosis fictitia. The patient will have signs and symptoms of hyperthyroidism without a goiter. So that is called as a thyrotoxicosis fictitia. So this is how you differentiate it. Okay. So there was a very intelligent question. What is hyperthyroidism? What is thyrotoxicosis? So in that, I am adding one more, thyrotoxicosis fictitia. So I think that was the last thing that I had to tell you about thyroid and your questions. Now let us go on to galactorrhea. Now this is the thyroid hypothalamo-pituitary thyroid axis. As you can see here, there is a hypothalamus here that secretes the trophic hormones, and then from pituitary the other hormones are secreted. Now this anterior pituitary secretes growth hormone, TSH, ACTH, FSH, LH, and prolactin. And all these hormones are stimulated by hypothalamus. So there is a positive feedback, negative feedback that I have explained to you last time. So these hormones are secreted by pituitary. So if we are, okay, let me go ahead. What is prolactin? Prolactin is secreted by lactotroph cells of anterior pituitary. It is a hormone which contains 199 amino acid peptides. The gene, because it is a protein, so it must have a gene, and that gene is located on chromosome 6. This chromosome also has homologous proteins for prolactin, growth hormone, and human placental lactogen. Lactogen, because it is going to produce the galactorrhea. So prolactin, growth hormone, and human placental lactogen, they share a gene. And therefore, till 1970, the prolactin could not be isolated or differentiated from growth hormone. So we were at a loss. The patients used to present with acromegaly, and we used to do growth hormone, which may be normal, and we used to wonder what could be the cause. Okay. After 1970, when we had a sensitive radioimmunoassay, because till then we had bioassays. When we had sensitive radioimmunoassays, which were first developed by Dr. Rosalind Yalow, for which she was given a Nobel Prize. And I was fortunate to meet her here in Mumbai in the Radiation Medicine Center. So Rosalind Yalow, when she developed this radioimmunoassay, we could separate out all these hormones. Now we are talking about hyperprolactinemia. You know, Talmud, this is a religious textbook of Judaism. It is also called as Hebrew Bible. Am I audible, Preeti? It is also called as Hebrew Bible. And that Bible gives a story. A man nursed his baby after untimely demise of his wife. So probably this was the first documented case of galactorrhea. A man nursing his baby. That means the man was secreting breast milk, galactorrhea. Okay. So this was the first documented evidence of galactorrhea in the historical era, and this is from Hebrew Bible. It was Riddle in 1930 who identified a hormone in non-human animals which stimulated lactation. Because it stimulated lactation, he named it as prolactin. So it was in 1930 that it was labeled or identified as prolactin. What is galactorrhea? Galactorrhea is inappropriate discharge of milk containing fluid from the breast, both in women and men. It may be clear, watery, it may be milky, or it may be bloody. If it is bloody, you have to also look for if there is a ductal carcinoma. Okay. So it may be watery, it may be milky, it may be bloody, it may be spontaneous. The patient herself will tell you, and she feels very shy that there is some discharge from her nipples. Or you have to look for it by nipple pressure. The milk secretion continues after cessation of breastfeeding. So that is called as galactorrhea, seen both in women and men. It will be clear, watery, or it may be milky. It may be very small amount, 3-4 drops, or it can be more than that. Spontaneous or seen on nipple pressure, and it is present after cessation of breastfeeding. What is the physiology of prolactin? It is circulating in 3 forms. Monomeric, it is called as a little prolactin, which is most active. It is 23 kilodalton in weight. Then dimeric, little bigger prolactin, and polymeric form, that is big prolactin. Prolactin regulation. It is regulated by neuroendocrine neurons in the hypothalamus via dopamine. Okay. So the hypothalamus controls it by dopamine secretion. Now other hormones which come from hypothalamus and reach the pituitary, they are stimulatory, like gonadotropin releasing hormone here. Gonadotropin releasing hormone or thyrotropin releasing hormone. They are stimulated by neuropeptidases, they are stimulatory. But this dopamine is inhibitory to secretion of PRL. Dopamine is inhibitory to secretion of PRL. So that is a big clue. So if there is a hyperprolactinemia, we should use dopamine to inhibit it. Have you understood that? So dopamine is inhibitory to the secretion of prolactin. What are the functions of prolactin? The maintenance of corpora lutea function. In the menstrual cycle, you know, after the ovulation, what remains behind is corpora lutea, and that goes on secreting progesterone. So that is under the control of prolactin. Most important, stimulation of lactation through its actions on the mammary gland. Prolactin, along with insulin and corticoids, stimulate the development of the mammary gland during pregnancy. With these small examples, you know, I have developed my faith in the God. Just imagine kitna chota cheez hai, and that is taken care of. So during pregnancy only, the mammary glands develop so as to prepare it for lactation at parturition. You know, the breast development takes place as a secondary sex character. But that is slightly different than during pregnancy, because in pregnancy, there is a hyperplasia of these glands which are going to secrete the breast milk. So prolactin along with insulin, corticoids stimulate the development of the mammary gland during pregnancy so as to prepare it for lactation at parturition. Before parturition, before delivery, there is no breast milk. So it is all, what shall I say, prepared and ready. And the moment the baby sucks it, the flow of the milk starts. Isn't it wonderful? The nature or God, whatever you call it, such a wonderful thing and so intricately controlled. It also controls the regulation of maternal behavior. So maternal behavior, anxiety, breastfeeding during pregnancy, anxiety during pregnancy and breastfeeding behavior, all these are under the control of prolactin. What are the causes of increased prolactin level? So as I told you, galactorrhea, the cause is increased levels of prolactin. Now, what are the causes? There are physiological causes. The prolactin level, if you are measuring as a research work, it is physiologically, it increases, the level slightly increases after coitus, exercise, deep sleep, or even with the stress. Pregnancy, naturally it increases. Lactation and suckling response. The moment the child shows the suckling response or puts the child to the breast of the mother, the milk will start. And the depression, the prolactin levels will increase. What are the other causes? There are drugs and systemic diseases which increase the prolactin levels. So remember the drugs. Estrogens, oral contraceptives can cause galactorrhea. Neuroleptic agents, antipsychotics, dopamine receptor blockers, dopamine synthetic inhibitors, because all dopamine is inhibitory. So whatever is increasing dopamine, decreasing dopamine level, like dopamine blockers, dopamine inhibitors, that will increase the prolactin levels, and opiates. But this will be present as long as the drug is continued. The moment you withdraw this drug, within 4 days, the galactorrhea will stop. Which are the systemic diseases associated with high levels of prolactin? Chronic renal failure, hypothyroidism, cirrhosis, PCOD, cranial radiation given for some malignancy, then epilepsy and chest wall trauma. Just 1 minute. Sorry, there was Amazon delivery boy at the door. Okay. So systemic diseases, cranial radiation. For some malignancy, nowadays we give a lot of cranial radiation that can cause it. Epilepsy and chest wall trauma. Chest wall trauma behaves like, suckling reflex, and the patient can get galactorrhea. Other causes are hypothalamic causes. Now, hypothalamus is connected with to the pituitary by a stalk. So damage to the stalk, that means dopamine is not reaching pituitary, high levels of prolactin. Granuloma, infiltration, trauma or surgery of the hypothalamus, stalk resection. The commonest thing that you know is craniopharyngioma and cyst of Rathke's pouch. So these are hypothalamic causes. Not very common. We will not see them in the family practice, but just to complete the causes of hyperprolactinemia, I have given you. So there can be physiological causes, there can be because of the drugs, there can be because of systemic disorders, and then there can be hypothalamic problems. But majority of our cases are because of pituitary tumors, prolactinoma, acromegaly. These will cause high levels of PRL. These prolactinomas are divided as microadenomas and macroadenomas. And then there are certain the tumors of the pituitary which are plurihumoral adenomas. So they are secreting multiple hormones. What are the clinical features? Hormonal dysfunction in premenopausal women. Now, one we have understood galactorrhea is a milk secretion or milk-like substance which is secreted from the breast when it is not supposed to be. That means outside the pregnancy, outside the lactation period. Okay. So what will be the effect? Because it is, the galactorrhea is because of the high prolactin levels. What will be the what will be the effect of this high PRL on other systems? Now, this high PRL, it inhibits gonadotropin releasing hormone. Okay. Because gonadotropins are not released, there will be hypogonadism. And therefore, in a premenopausal woman, there will be scanty menses, secondary amenorrhea, anovulatory cycles, leading to infertility. Decreased libido, dryness of vagina, painful sex, and hot flushes. And most important, galactorrhea. So patient presenting with galactorrhea may complain to you scanty menses, secondary amenorrhea. In other words, if there is a case of secondary amenorrhea, or if there is a patient who comes with infertility or scanty menses, please press the nipples. Ask the patient to press the nipple, or you can press and see if you can express any fluid from the nipples. In that case, you will ask for a prolactin level. Okay. So this prolactin inhibits the gonadotropin releasing hormone, therefore hypogonadism. And what are the manifestation of hypogonadism in a woman? Premenopausal women, of course, because after menopause, menses will be absent. So premenopausal women, scanty menses, secondary amenorrhea, and ovulatory cycles, and therefore infertility. Decreased libido, dryness of vagina, and because of the dryness, there is painful sex, hot flushes, and galactorrhea. In men also will come with galactorrhea and gynecomastia, enlargement of the mammary gland. There will be hypogonadotrophic hypogonadism, decreased libido, erectile dysfunction, and infertility. So remember, prolactin is one of the important hormones when you are investigating a case of infertility. Then there can be compressive features. If there is a pituitary adenoma, there can be a suprasellar extension causing headache, restriction of field of vision, or visual impairment. Or it can infiltrate into the cavernous sinus and cause neurological deficit, because in the wall of the cavernous sinus, there are 3 cranial nerves which are running. All right. So compressive features. What investigations you will do? If a woman comes with a galactorrhea, first do a urine pregnancy test. Because if UPT is positive, then the galactorrhea is related to the pregnancy. But if it is negative, then you will do thyroid function, FT3, FT4, TSH, serum prolactin level, serum growth hormone, insulin-like growth factor if possible, and cortisol. In addition to this, in males it is hypogonadotrophic hypogonadism. So you will do serum testosterone in the males. So these are the hormonal investigations you will do. For compressive features, perimetry and MRI. I will not go into the details. Now, how do we manage? Management, if the patient is hypothyroid, TSH is high, and if the prolactin level is less than 60 nanograms, then treat the patient only with thyroxine. Eltroxin, Thyronam, Thyrox, whatever. So hypothyroidism, associated hyperprolactinemia, if the prolactin levels are less than 60, then only they will respond to thyroxine. That means treatment of hypothyroidism. So you correct the hypothyroidism, prolactin will become normal. But if it is more than 60, whether hypothyroid or euthyroid or any other patient, if the prolactin levels are high, not hypothyroid, but other patients where prolactin levels are high, more than 60, then we should use dopamine agonist. There are two types of dopamine agonist. One is bromocriptine and the another one is cabergoline. Okay. Now, bromocriptine has to be taken twice a day. So the patient's compliance is a problem. The side effects are slightly more. So the newer drug is cabergoline. Cabergoline, we have to start with a small dose. And the dose is 0.25 milligram once a week. Or you can still start a smaller dose, 0.125 milligram. That means half a tablet once a week. Next week, you can increase it half a tablet twice a week. So that becomes 0.25 milligram. Go on titrating. Every fourth week, you will see the prolactin levels. And go on titrating till the prolactin comes to normal. The maximum dose that you can give is 1.5 milligram thrice a week. See, the tablet is of 0.25 milligram. Maximum dose is 6 tablets thrice a week, not more than that. And once there is, you have confirmed that there is a prolactinoma, the galactorrhea will respond immediately, but you have to continue the treatment for 2 years. So cabergoline tablet is 0.25 milligram per week. So ask them Sunday to Sunday. Or you can start with a small dose of 0.125 Sunday and Thursday, something like that. It depends on all of you. So you can start with a smaller dose and go on increasing. I had done a study, I had told you, of prolactin levels in hypothyroid patient, and I had taken about 100 patients. This is the normal level in females and this is in the males. The prolactin levels normal in 110 cases. The prolactin 24 to 60 nanogram was in 31 cases. So in the females, it is 23 nanograms. In the males, it is 15 nanograms. So more than that is hyperprolactinemia. But prolactin 24 to 60, that means it was high. In how many patients? 31 patients. And that is because of the increased sensitivity of lactotroph cells to TRH. So these were hypothyroid patients. In 31 hypothyroid patients, only the prolactin level was between 24 and 60. I treated them with thyroxine, galactorrhea disappeared, prolactin levels came down. If more than 60, the serum prolactin was more than 61 to 300 nanograms per ml. I had 19 such patients. Out of these 19 patients, 9 patients had microprolactinoma on MRI of the pituitary. And all these 19 patients I had to treat with thyroxine for hypothyroidism and cabergoline for hyperprolactinemia. Okay, so you can give this combination to the patient, continue thyroxine for lifelong, cabergoline for 2 years. And this is one patient that I would like to show you. This patient came with acromegalic features. Look at her face. Look at her lower jaw. It is slightly protruding outside. That is her husband. And look at her side. If you see her hands and feet, there was an enlargement. That is called as an acral enlargement. Her growth hormone levels were normal, but the prolactin level was 189 nanogram per ml. The insulin-like growth factor also was raised. I treated with her. Naturally, she came with secondary amenorrhea, infertility, not conceiving, this, that, all those, and the acral enlargement. She had to change her shoes every 3 months because they couldn't fit. So acromegaly. So I did her growth hormone level, which were normal. So did prolactin 189. Treated her with cabergoline. As the prolactin levels came down, the gonadal functions restored, and she delivered a baby within 2 years. That is the baby. So this is by Price case. Her present prolactin level is only 26 nanogram per ml. Adenoma totally suppressed. Microadenoma in the pituitary totally suppressed. Okay. But acromegalic features can't disappear because there is acral enlargement which will remain. So now she is a very happy mother. So what I am trying to say, that all these things are treatable and you should give the proper therapy to the patient. Is the surgery advocated for these prolactinomas? If they are bigger than 3 centimeter in size, you can advise surgery. If the patient is not responding, very rarely, to the medical treatment, then you can give. Occasionally a patient not responding to medical treatment, but sometimes what happens, the patient is anxious for pregnancy, so she is not going to wait till the prolactin levels come down. So she says, okay, do my surgery, let that prolactinoma be relieved, let me conceive. In such anxious patient, you may subject them to surgery. And what is the surgery? Transsphenoidal resection of that prolactinoma. And the results are really rewarding, as I have shown you. So what is the conclusion? Cases of gynecomastia. Gynecomastia is breast enlargement in the males. So cases of gynecomastia, galactorrhea, infertility, amenorrhea, acromegalic features should be subjected to serum TSH, serum prolactin, serum growth hormone, insulin-like growth factors, and serum testosterone in males. All this will help you in arriving at a proper diagnosis and proper treatment. Because it is hypothyroidism, prolactin less than 60, treat only with thyroxine. But hypothyroidism and prolactin is more than 60, eltroxin plus cabergoline. And if it is pure prolactinoma, dopamine agonist, cabergoline, which has to be used starting with a smaller dose and treatment continued for 2 years. So I think that is all that I wanted to tell you about galactorrhea, which is quite common. Now, let me also tell you that in spite of all this, sometimes you get idiopathic galactorrhea. Just when you press the nipple, a drop of watery fluid will come out. That is just idiopathic. It may be a stress or anxiety. So you have to only reassure a patient. But before that, you will rule out a prolactinoma. That's all that I wanted to share with you. Thank you very much for your patient hearing.
Thank you,
Okay,
ma'am.
Preeti?
Yes, ma'am. Thank you. So the questions I'll share with you so we can discuss them in the next session.
What is the importance of insulin-like growth factor? I'll do it some another time, because I'll have to explain to you what is insulin-like growth factor. Thank you.
Thank you, ma'am. Thank you, everyone. See you next Thursday.
If you have any questions, please send them to Preeti, and whenever I get time, I'll meet you again and talk about it. Okay, so thank you very much.
Thank you, ma'am.
Stop here.
Yes, ma'am.